Okay, this video is going to be called Kidney Failure Vicious Cycle. And what I'm actually doing is I'm going to go through a paper written in 1982 by in the New England Journal of Medicine. I'll show you the paper in a minute, but I want to go through this picture so everything will make sense to you. You have an artery that comes into the kidney. This is a nephron, the filtration unit of a kidney. And the purpose of this lecture is I'm going to help teach you how to protect yourself from kidney failure because it's very common. Okay, when a person eats animal protein, they get dilation of the incoming artery. It's called the afferent artery. You can remember afferent for approaching. They both start with the letter A. Afferent and approaching. Okay, that artery comes into the filtration unit of the kidney called the nephron. The nephron looks like a little claw, and it's called Bowman's capsule. And this is also called the glomerulus, the capillaries that run in the center of it. Then what also happens in the context of eating animal protein is the kidney has to work harder to excrete the nitrogen. There's only nitrogen in protein. There's no nitrogen in carbohydrate or in fat. And it's the kidney's main job is to excrete that extra nitrogen. When you eat higher amounts of protein, you're eating more nitrogen and you're creating increased work for your kidney. And the work is especially increased when you eat animal protein, because animal protein is different than plant protein. Animal protein is much more acidic, in particular because of the methionine, a sulfur-containing amino acid, whereby some of that sulfur is degraded to sulfuric acid, causing a metabolic acidosis, and the kidney has to excrete the extra protons to buffer away that acidosis. Okay, so the way the kidney will excrete the extra nitrogen is it'll narrow the efferent artery. So E for efferent, and E for exiting artery. So that's how you can remember that. That's worth knowing for the rest of your life. A for afferent approaching, E for efferent exiting. Okay, so when you vasoconstrict the outflow artery and you dilate, this is dilated, the inflow artery, that means more blood is rushing into the glomerulus, the capillaries of filtration in the kidney. So more urine is filtered into Bowman's space. And then this is heading out to the renal tubule before it's excreted down into the urinary bladder and you urinate it out of your body. Okay, so this side is pretty much normal. Okay, these are the capillaries. This is a thin blue line for the glomerular basement membrane. These light blue cells are normal mesangial cells. Okay, what happens though with chronic hyperfiltration, chronic dilation of this artery and narrowing of this artery, you get increased pressure in the glomerulus. So you get hypertension in the glomerulus. So this is inside of glomerulus hypertension. So the point is when you are pumping high pressure into your kidney around the clock because you're always eating high protein meals, you are beating up on your kidney. You are overworking it. And it starts to respond to that. You leak some albumin, the protein, into this mesangium. This little space in here in the middle is called the mesangium or the extracellular matrix. And then these mesangial cells start to hypertrophy and they release fibrotic tissue and it starts to sclerose off and you get sclerosis, fibrosis of your glomerulus. That's a bad thing. You also get thickening of this blue line here is thickening of your capillary basement membrane. That's a bad thing. It normally has a good zeta potential negative charge on these red capillaries, this blue glomerulus, and that contributes to the filtration having what is called a charge selectivity barrier because the negatively charged endothelium and the negatively charged glomerular basement membrane, they repel the albumin. Albumin is the protein floating in the blood, and it also has a negative charge. So the negative charge can be called the zeta potential, and they all repel each other. That's exactly what you want. You don't want the albumin going into the urine. Okay, but once you damage the glycocalyx, the negative charge of the capillaries, the endothelial cells are the lining cells, and you damage the zeta potential, the negative charge of the glomerular basement membrane. Now the negatively charged albumin can leak in here. These little green dots are the albumin, okay? The urine that first comes into Bowman's capsule is called the primary urine. As it travels down the tubule, some of it gets processed in a sense. You know, we try to conserve water during the feeding intervals so we don't dehydrate. And as you process the urine more, then it will no longer be called the primary urine. Okay, but I just wanted you to see this. Okay, so this is a simplified view of it. Now I'm going to show you a slightly more detailed view. Okay, here's a more sophisticated picture of the kidney. And what it's showing you is normally this green stuff is the albumin. It should stay inside of the capillaries. You don't want that filtering into your urine. The little orange cells here are the endothelial cells. The purple is the capillary basement membrane, and the yellow are what are called podocytes. They're called pod means foot. So these are the foot process, just like a podiatrist is the foot. Okay. So anyways, they kind of look like little creatures. But anyways, that's normal anatomy. When you have chronic hypertension and chronic diabetes, which usually most of the time go together, you get what we just talked about, thickening of the capillary basement membrane, the purple here, okay? And that, and also the endothelial cells, they lose their zeta potentials, their charge selectivity, and you start leaking more protein into the urine. That's a very bad problem. We'll talk more about proteinuria. It's primarily what we're concerned is albuminuria. Albumin is the most common protein in the blood. It has a molecular weight of about 69 kilodaltons, and it is not supposed to get filtered into the urine. There's both a selectivity barrier due to charge and also a selectivity barrier due to size, and it does not belong in the urine. When you chronically have hypertension in the kidney and you're leaking some albumin into the mesangium as well, you will get hypertrophy of the mesangial cells. You can see how they're enlarged in here, and they're also starting to lay down. These lines are fibrosis. They call it collagen deposition. That's fibrosis, and it's usually referred to as sclerosis, glomerular sclerosis. So collagen deposition, fibrosis, and sclerosis, for our purposes, are essentially the same thing. And you will gradually destroy this nephron until eventually it stops working completely. Okay, but the reason I'm giving this talk is what I'm trying to tell you is this process will start to accelerate, and it will become a vicious cycle. And the further along somebody gets, the harder it is to reverse it or slow it down. So this has a lot of clinical implications. So I'm going to show you an old paper that I've already talked about, but then I'm going to show you the new paper that I haven't talked about with you yet. And trust me, this is leading to something useful. It helps you to understand what to do to protect yourself from these diseases. So rethinking glomerular basement membrane thickening and diabetic nephropathy, okay? So, diabetes, most common cause of kidney failure, and hypertension too. They both go together. Most people have both of them. Okay, so it's like warning lights in a car. Abnormal fasting blood glucose, abnormal hemoglobin A1C, that's a measure of glycation of the hemoglobin in your red blood cells. When you got microalbuminuria, your engine is on fire. Okay, so the natural history of diabetes is that it has a relatively long, clinically silent period where the patient thinks they're doing okay. You ask them, how's your diabetes? They go, oh, it's under control, it's under control. They're too stupid to realize that if they simply ate a low-fat vegan diet, they could probably cure themselves rather than try to control it with pills. And they're often silently damaging their kidneys. And by the time they realize it, it's quite often inevitable that they're going into kidney failure. Now, the catch is that they actually, let me go back to that because I think I missed a page here. Okay, let's see here. Okay, so that was the beginning page. Here's where it says, I wanted to read you what this other paper said, that the natural history of diabetes begins with a long clinically silent period during which the patient remains normal albuminuric, meaning no albumin in the urine, and they have a relatively normal or even high glomerular filtration rate. However, during this clinically silent phase, structural lesions develop, including glomerular basement membrane thickening, which is associated with loss of zeta potential, mesangial expansion, enlargement of those central matrix cells like we talked about, and glomerular sclerosis, destruction of the glomerular capillaries. Once microalbuminuria is clinically apparent, the structural lesions are often considerably advanced. So what they're saying there is by the time you can detect the albumin in the urine, usually their kidney failure is already far progressed. And GFR decline may then proceed rapidly towards end-stage renal disease. That means being on dialysis. So what they're basically saying is by the time you wake up and realize that the patient's kidneys are being destroyed, it's quite often too late, and you cannot slow it down. Indeed, treatment initiated after the onset of overt diabetes nephropathy typically cannot arrest progression. You want to know what often arrests progression, stops these patients from ending up on dialysis? They die, okay? They get lots of atherosclerosis associated with kidney failure, and they often have a heart attack and die, all right? That's why there aren't even more patients on dialysis, because they're dropping dead of heart attacks left and right. And once they go on dialysis, they usually die pretty fast. It's like 25% die in the first year. Okay, so like I said, like on a car, these are warning lights: abnormal fasting blood glucose, hemoglobin A1C, microalbuminuria, and also hypertension. Okay, now I'm going to go through this other paper And because I just want to show you, this has been known for a long time. So here's the name of the paper, The Role of Hemodynamically Mediated Glomerular Injury. So hypertension-related glomerular injury in glomerular sclerosis, in glomerulus kidney nephron fibrosis associated with aging, but also with renal ablation, intrinsic kidney disease, disease inside of the kidney. Author is Hostetter et al., New England Journal of Medicine, September 1982. Okay, the reason I went through that is this was known back in 1982, and they've known it longer. Kempner was curing people back in the 1940s, 50s, 60s, and 70s. Okay? Kempner figured out what to do back in the 1940s, and these dummies at the Ivy League hospitals still had not figured it out today in 2024. Okay? It's 2025. It's ridiculous. Okay? This video has been made in March 2025. Okay. Renal disease tends to follow an inexorably progressive course. And they say that he said that kidney disease, once it gets going, it just keeps on going faster and faster till the patient's kidneys are trashed and they're on dialysis. And my response here, I'm putting a little commentary in red here, that's because you idiots don't treat with a very low protein diet. Now, don't get me wrong, the authors of this article are actually pretty smart. They are recommending a very low protein diet, and they're even saying consider keto analogs, consider essential amino acid supplementation. Those are special supplements of deaminated amino acids. Okay, that means take amino acid where you take the nitrogen out of it to feed them. Okay. So here's how they describe what's happening. Excreting nitrogen, or the urea is the processed form of nitrogen. It creates work for the kidney. That's the kidney's main job. And that increase in work is manifested in animals and humans as a transient increase in glomerular filtration rate due to hyperfiltration. Just like I was showing, you're pumping more blood through the glomeruli because you're dilating the afferent incoming artery and you're constricting the outflow, the efferent artery, which means that it has to go somewhere, so it gets filtered. More of the plasma. Okay, humans given amino acid rich, so high protein TPN, total parenteral nutrition, that means feeding by an IV, will get a 50% increased GFR compared with during the nutrient-free interval, so the interfeeding interval. During nutrient-free phase, the key goal is conservation of water and electrolytes. Immediately after eating a high-protein meal, the key goal is get rid of that excess nitrogen. Okay. The average daily intake of protein in Western men is about 100 grams of protein per day. That's insane. That's insane. Do you understand that the average person really only needs about 25 to 30 grams of protein per day? And they're eating like 4 times what they need? At least 3 times, potentially 4 times. It depends how big the person is. It depends how much they exercise, etc. Okay, but the point I wanted to make is we are massively overeating protein. Massively. All right? A very low protein diet. It's in the ballpark of about 25 grams of protein per day. Of course, these things matter a little bit based on the weight of the patient. Okay, the authors did not specify animal protein, and my impression from reading the article is that these authors do not know the difference between animal protein and plant protein. Animal protein is worse for many reasons. Number one, it has a lot more methionine. It's acidic, so it generates acidity, and the kidney has to also do work to buffer the pH, the acidity. In addition, animal protein is associated with increased phosphate load because the phosphate in animal foods is more bioavailable, and also modern meat's often a processed food where they add phosphate to it, phosphate additives. In addition, there's no fiber in meat, and you tend to have more leaky gut, leading to more inflammation associated with that, postprandial endotoxemia and all that stuff. With meat, you get xenocellulitis, you get TMAO. All of these things contribute to increased inflammation and increased filtration burden placed upon the kidney. So the kidney has to go into hyperfiltration. And they do describe a concept of having to recruit a bunch of neurons are sort of during the interfeeding intervals. So when you're not eating, nutrient-free intervals, your kidney mostly focuses on conserving water and electrolytes. And it uses the especially long-length nephrons to do that. They're better at doing that. When you eat a big protein meal, especially animal protein meal, you have to recruit more nephrons, the kidney filtration units. So you'll use those that have shorter filtration loops of Henle. Okay. And so, let's see. In animals and humans fed ad libitum, meaning all you can eat, they overload themselves with protein quite often if it's available. And this will cause unremitting, unrelenting, nonstop hyperfiltration. throughout the glomeruli, including the ones that are usually at rest. And the authors of this paper, they speculate that human overindulgence in all-you-can-eat protein leads to accelerated aging-related CKD, chronic kidney disease, because they see this over and over in lab animals. They can feed them all you can eat, the lab animals, high-protein meals, and they more rapidly go into kidney failure. You can take out one kidney, and then the other kidney will go into kidney failure more rapidly, especially if they're eating the high-protein meals. If you remove one kidney, for whatever the reason, you can surgically remove it, you can ablate it with chemicals, the other kidney will fail faster than expected because of the nonstop, unrelenting hyperfiltration, causing progressive, albuminuria, albumin leak into the mesangium, mesangial expansion, mesangial fibrosis, glomerular sclerosis, hyalinization, like protein deposition along the walls of arteries, for example. And the point I'm making here, like, why am I going through all this? Because it's a vicious cycle. So what I'm saying is, the worse it gets, the faster it accelerates to complete failure in dialysis. So what does this mean? It means that you don't want to end up in the danger zone. You don't want to be in mild kidney failure. You want your kidneys to function perfectly normal. And the way you protect your kidneys is protect them from animal protein, okay? And protect them from high-fat diets, protect them from excessive amounts of sodium. Sodium is a vasoconstrictor, and that will decrease blood flow to the kidneys, and that can cause kidney injury over time. You also get into issues with electrolytes and hypertension. If you're eating high sodium, you tend to be eating low magnesium and potassium, and you tend to end up hypertensive, and you get hypertensive injury to the kidneys. Okay, but the other point I want to make is most patients, like when I look into a chart, usually if they've got diabetes, they also have hypertension. It's uncommon to see diabetes without simultaneously seeing hypertension. And a patient might start out with hypertension alone, but they're quite often pre-diabetic and on their way to becoming diabetic. Okay, let's see here. When you remove one kidney, you get about a 40% increase in blood flow in the other remaining kidney, and that pushes it into more frequent hyperfiltration. Okay, and it leads to an acceleration in glomerular sclerosis, kidney failure. In rats, if you can restore glomerular hemodynamics to nearly normal by protein restriction, that's associated with preservation of the glomerular architecture, meaning you do a biopsy of it and it still looks normal, and an absence of protein leak, proteinuria. This has been confirmed in many subset groups, including after unilateral nephrectomy in rats, or rats even treated with hypothalamic injuries to their hunger center in their brain, so they eat more. So the point was, even if the rat overeats, as long as it eats low protein, the kidneys are protected. In human patients, once their GFR, glomerular filtration rate, drops to 25, it's like stage 4 kidney failure. Stage 3 is 30 to 60 GFR, okay? Stage 5 is like below 15 when you're on dialysis. So here's an important point. Regardless of the cause, it doesn't matter why the kidney failure occurred. Once they've lost so much kidney mass that their GFR is down to 25, what the author is saying is they're basically screwed. They're almost always going to continue on to dialysis because the remaining nephrons are now doing the work of all the previous 2 normal kidneys, and they just can't handle it. They're overworked and they fail, and you're on dialysis. You're screwed. But again, they are not mentioning that you can sometimes save these patients for a prolonged amount of time. You might not forever keep them off of dialysis, but you can sometimes keep them off for a couple of years. Maybe at least 1 year. You got a chance, go for it. That lady Jennifer Moore, the dietitian, has written about keeping patients off a year or more. Kempner did it. Lee Hull writes about this. It's like, why the hell not go for it? Why not go for the chance to protect yourself from dialysis? Dialysis is something you only do if you have to. You don't want to do dialysis. Like I said, 25% dead by the end of the first year. Okay, so here's the conclusion of these authors. Back in 1982, restriction of dietary protein relatively early in the course of renal disease slows the rate of decline of kidney function. Well, no shit, okay, because you diminish the workload of the kidney, and so it doesn't go into this hyperfiltration so often, and therefore it doesn't progress to fibrosis, doesn't progressively lose protein. And what I'm also saying is there's kind of a meme going around the internet that, older people need more protein or they get sarcopenia. And my response to that is BS. I agree with McDougall and Pritikin. Those 2 guys are geniuses, and they both said it's impossible to be too low in protein on any naturally chosen diet, okay? I've never seen a protein deficiency patient in my life, okay? All day long I see protein excess patients in kidney failure, okay? Every day I see a bunch of them, okay? Tons of them, all right? And so, yeah, who gets sick? High fat, high protein eaters, okay? Who is healthier? Low fat, low protein plant eaters, okay? So what I'm saying is, I don't believe this BS about people needing more protein. It's like accelerating your kidney failure. And animal protein in particular is even worse. T. Colin Campbell wrote all about that, how animal protein has an anabolic effect on the body that leads to high blood cholesterol, which then leads to accelerated atherosclerosis and increased hypertension. You don't want that, okay? Remember, we talked about populations like the Yanomamo and the Kenyans when they ate a plant-based diet back in 1929. They don't ever get hypertension. They're in their 70s. They got the same blood pressure as when they're teenagers. The average Kenyan who is 60 years of age who ate a plant-based diet, they had an average blood pressure. This is a male Kenyan, 60 years old, had an average blood pressure of 105/67. Okay, what else does he say? He says, in patients who had serum creatinines of average of 2.2, moderately elevated, it's pretty bad, when put on 30 to 40 grams of protein per day, that's almost a very low protein diet, close to being 0.3 grams per kilogram per day. That's really looks to me like about 0.4 grams per kilogram per day. They had no fall in GFR for over 2 years. And the comparable patients starting out with this type of creatinine, serum creatinine, they all progressed. So very low protein diet with essential amino acid supplements or keto analogs are promising methods of treatment. Also, losing weight to optimize body weight leads to a reduction in proteinuria. Well, guess what? When you go low-fat vegan, low-protein vegan, you reduce your intake of protein. You reduce your intake of phosphates. You reduce your intake of sodium. You increase your dietary fiber, so you avoid all those gut toxins related to high-fat diets. You avoid indoxyl sulfate, you avoid indole acetic acid, you avoid p-cresyl sulfate, you avoid TMAO, trimethylamine oxide. You avoid all that stuff. You avoid postprandial endotoxemia, okay? You protect your kidneys in numerous ways, and you optimize your body weight if it's a low-fat plant-based diet. All of that stuff protects your kidneys, protects your heart, protects your brain, protects your Johnson. Why wouldn't you want that? So the author's conclusion of this paper was that a review of the literature as well as their own research experiments have confirmed or are consistent with their hypothesis that sustained hyperfiltration, meaning animal protein eating, accelerates proteinuria, loss of protein in the kidney, a very bad sign of kidney failure, and glomerular sclerosis, fibrosis of the kidney causing kidney failure. Duh! So the reason why I'm going through all this is I can tell you, the doctors in 2025, they still don't know this. The average nephrologist, kidney specialist does not know this. And they don't, on average, treat these patients with these low-protein vegan diets. So it's a tremendous therapeutic opportunity is being missed. And you as an individual, you have to realize you're on your own. These doctors can't save you if they're a bunch of ignoramuses. So it's freaking obvious. You want to be low-fat, low-sodium, low-protein, vegan with no added oils. It's obvious.